This week's lesson is about gastrointestinal infections and food poisoning. Foodborne illnesses are an important public health challenge. Several organisms previously not considered as foodborne and other significant pathogens have emerged and are continuously being recognized as human pathogens transmitted by food. These new, if you may, discoveries are probably a result of one, recent acquisition of key virulence factors, two, detection by newly developed laboratory methodologies, and three, astute investigative work of clinical microbiologists. Because of the large amount of material to be covered, as just like our other lectures, this presentation is divided into two parts. This is part one, where we will talk about the role of the normal flora found in the gastrointestinal tract. And as part of that objective, for you to be able to explain this role of the normal flora in health and in disease. Be able to list the organisms that make up the colon flora. Differentiate the two types of pathogenic mechanisms involved in acute bacterial diarrheas. Be able to associate the common food vehicles and the specific pathogen or toxin responsible for the illness. Continuing on, be able to describe the parameters that may be used to evaluate gastrointestinal illnesses. Give the sources of infectious agents presented and describe how they are acquired. And for each of the organisms described in this lecture, be able to give the clinical manifestations of each infection, describe the method of diagnosis and general characteristics, including morphology on different selective media used to isolate and recover these organisms, and be able to use key biochemical test reactions to screen for these specific pathogens. In part two, we'll be able to differentiate the organisms listed from the normal colonizing flora of the gastrointestinal tract using the set of conventional two-media reactions, the TSI or triple sugar iron agar, the reaction on citrate, LIA or lysine iron agar, urea, and SIM, that is sulfide, indole, and motility. We also briefly will describe the etiology of the following non-bacterial food poisoning. Those described as ciguatera, scromboid poisoning, anisakiasis, and that of a condition caused by Helicobacter pylori. As a way of introduction, on August 13, 2010, Wright County Egg of Galt, Iowa, conducted a nationwide voluntary recall of shell eggs that it had shipped since May 19 of 2010. Shell eggs from Wright County Eggs were sold to distributors and wholesalers in 22 states and in Mexico, who then distributed the shell eggs further throughout the country. Numerous outbreaks occur annually, from peanut butter contamination, food poisoning events from eating at Chipotle, and other food recalls such as cheese and other food products. Millions of people suffer from foodborne illness yearly. And while most of us experience self-limiting events, others suffer from serious forms of the disease. Now, during the past 3 decades, the epidemiology of the foodborne diseases has evolved as new pathogens emerge. Let's look at our case in point. A 32-year-old man who traveled to a small village in Mexico and experienced a sudden onset of diarrhea 4 days after his arrival. He complained of nausea and his stool was watery, but without gross blood, identified pus or mucus. He also had no fever. So in evaluating a foodborne illness or a gastrointestinal infection, these are some points that we would like to consider. Which of the clinical findings are significant? What are the travel and food intake histories? And why is this information important to both the clinician and the microbiologist? What pathogenic mechanism is employed by the suspected agent? And how can we determine that pathogenic mechanism? How would you differentiate food poisoning from gastrointestinal infection? What methods of recovery would be appropriate? And other points to consider as we go through this presentation. So as a way of introduction, let's first take a look at how bacterial diarrhea and other gastrointestinal infections are acquired. Gastrointestinal infections are obviously usually acquired via ingestion of the organisms in contaminated food or water. Hence, it is appropriate to take a look at how these organisms interact with our immune defense mechanisms in the gastrointestinal tract. So to begin, once food reaches the stomach, gastric juices and enzymes are released, and those organisms that survive the antibacterial enzymes, such as lysozymes secreted in the saliva, will be attacked by the gastric juices. Nevertheless, something to remember is that spore-forming bacteria and cysts of amoeba are still likely to survive the gastric acidity. Now, organisms that survive the gastric juices will travel down the small intestine. The peristaltic movement in the small intestine serves as a defense mechanism so that those pathogens that utilize adherence as a virulence factor are at a disadvantage. That is the reason why hypermotility in the small intestine during gastrointestinal disease is a protecting mechanism to wash away naturally these invading organisms. That's also one of the reasons why in some cases it is not a good idea to take those anti-diarrheal over-the-counter medication, because actually diarrhea is a way of the body to eliminate whatever is bothering your gastrointestinal tract, and that is through the hypermotility in the small intestine. So those that are able to attach may then initiate an infection. However, mucosal IgA serves as a protection unless the individual is deficient in producing this antibody. And again, once the hypermotility slows down because of your kaopectate or Pepto-Bismol, then it slows down, and those organisms that are able to attach may then initiate an infection. So, and then lastly, the gut flora will try to eliminate the invader by its presence. Remember how organisms compete for food and space. Like we mentioned before, acute diarrheal illnesses which could be due to foodborne pathogens, is one of the most common ailments that afflict man. Although most suffer a self-limited form of the infection, others may experience more severe forms, such as chronic diarrhea, subsequent bacteremia, and severe dehydration. Chronic sequelae has also been described. As I just mentioned, certain sequelae have been described with certain associated organisms and foodborne pathogens, including, for example, Listeria monocytogenes has been reported to produce the highest fatality rate and rate of hospitalization, while E. coli O157H7 is the most common cause of hemolytic uremic syndrome in children. Salmonella has been associated with septic arthritis, while Campylobacter species with Guillain-Barré syndrome. This is an acute demyelinating disease of the peripheral nervous system that was first thought to be an autoimmune disease, but now has recently been associated to post-campylobacteriosis. CDC estimates that in the United States, food poisoning causes about 76 million illnesses, 325,000 hospitalizations, and up to 5,000 deaths per year. And this figure represents the burden of illness, illustrating that what we know about the incidence of foodborne illness is just the tip of this pyramid. And the reason for that is, as we know, most people who suffer from diarrheal illness do not seek medical attention during the first 1 to 3 days of the illness. Most cases, therefore, are underreported or even unrecognized. Nonetheless, the approximate number of illness is in the millions, with thousands of associated deaths per year. The exact number of cases that occur is difficult to determine, while the estimated costs are in the billions due to loss in work productivity, sick time, medical intervention, including the loss the industry suffer during an outbreak. The concern over foodborne illnesses surround the fact that there are several factors associated with increased risk for this disease, and these include host susceptibility, changes in lifestyle, and changes in food delivery, even methods of preparation and production, and where food comes from. Certainly, we already recognize that those who are immune suppressed are most susceptible, the number of which has increased during the past 2 decades and tend to increase within the next several years. Those infected with HIV, deficient in IgA, and those who are placed in anti-immunosuppressive therapy. Antimicrobials, which usually accompany chemotherapeutic agents, also change the gut flora, which makes the gut more susceptible. And in addition to the toxicity afforded by chemotherapeutic agents. There are numerous and different possible causes of a diarrheal event. Differential diagnosis, both clinically and in the laboratory, will be very costly unless the clinician and the microbiologist develop a systematic approach. One of the most important events in this process is finding out the patient's travel history and ingested food during the past several days. Nevertheless, the clinician's utmost concern during physical examination of the patient is the patient's state of hydration. Fatal cases of gastrointestinal infections, especially in young children, is a result of massive dehydration. Therefore, laboratory diagnosis that may include direct smear of the stool to look for white blood cells, culture for bacterial pathogens, and examination for parasites hopefully will determine the cause of diarrheal illness. With regard to the most common agents of diarrheal diseases, you can see here that the majority of diarrheal illnesses are caused by bacterial species, about 50 to 75%. Viruses and parasites may also be implicated. However, most diarrheal events are either undiagnosed or the cause is not determined because of reasons that we have previously discussed. Now let's take a look at the different clinical syndromes and specific pathogens associated with a particular syndrome. We may also be able to associate the incubation period or onset of symptoms with the pathogenic mechanism employed. So for example, immediate onset or short incubation period is most likely due to or a preformed toxin mediated, while organisms that need to multiply before producing toxin or infection will take longer hours and perhaps days. So look at this table in particular and associate the incubation period with associated pathogens. So for example, nausea and vomiting that set in within 5 or 15 minutes of ingestion may be associated with heavy metals or chemical toxins, while nausea, vomiting, and diarrhea that occur within the first hour or two to about 18 hours may be associated with preformed toxins such as those produced by Staph aureus, Clostridium perfringens, Bacillus cereus, and enterotoxigenic E. coli. Now you notice that this is very similar to that produced in the incubation period caused by viruses such as rotavirus and norovirus. Diarrhea with abdominal cramps, and it takes a day to about 3 days. You will notice may be caused by Campylobacter jejuni and Shigella, and similarly with enterohemorrhagic E. coli. Those caused by parasites such as Microsporidium and Giardia lamblia will take at least a week or two. We can also associate the food vehicle of transmission. So certain food, by knowing the food history and travel history of the patient, we would be able to associate and determine what the possible diarrheal agent may be causing the patient's condition. As you can see in this table, undercooked chicken or any poultry can be a source of Salmonella and Campylobacter. Hence, eggs are common sources of Salmonella outbreaks and food prepared with eggs. It goes without saying why it is important to know the usual inhabitants of the organisms, where they are found in the environment, and their regular or usual hosts so that you can track how the food could have been contaminated. More recently, however, new food vehicles of transmission are implicated in foodborne outbreaks. Fresh produce easily becomes contaminated at the fields while growing, at harvesting, and in distribution. Improperly treated manure for fertilizers instead of chemical agents, and irrigation water contaminated with sewer are examples of sources of contamination. There are many processes involved from the time the food product is manufactured to the time it reaches the table that preventive strategies must address each of these processes. Let's continue this discussion of the clinical and laboratory diagnosis by looking at and starting with the pathogenic mechanisms and how it would be useful in the clinical and laboratory diagnosis of gastrointestinal and diarrheal infections. When the diarrheal illness has a short incubation period, that is, the patient experiences rapid onset, that is within a few minutes or a few hours, there is no fever, and no leukocyte is seen in the stool smear examination, we may be able to project that the illness is most likely due to an organism that produces an enterotoxin that is responsible for the clinical symptoms. So this is enterotoxin-mediated diarrhea. Examples of this are those forming preformed toxin, as mentioned previously, include Staphylococcus aureus producing enterotoxin B, Clostridium perfringens, Clostridium botulinum. While other organisms may require certain amount of time to colonize and multiply and then produce a toxin to initiate the syndrome. Colonization and toxin production mechanism is used by Clostridium difficile, Vibrio cholerae, E. coli 015787, and enterotoxigenic E. coli. On the other hand, a longer incubation period, fever, and inflammatory cells, including white blood cells and red blood cells, when present indicates that the condition is caused by an invasive organism. The following are the most common causes of invasive form of diarrheal infections. These include if the infection is localized, that is typical for non-typhoidal Salmonella, Shigella, Campylobacter jejuni, Vibrio parahemolyticus, Yersinia enterocolitica, and enteroinvasive E. coli. While systemic invasion is usually produced by Salmonella typhi and Aeromonas. Currently, there are 7 most common bacterial pathogens that are encountered in the clinical laboratory. Top of the list is Campylobacter jejuni. You may find Salmonella, both typhoidal and non-typhoidal, Shigella species, E. coli 015787, Listeria monocytogenes, Vibrio species, depending on your geographical location, as well as Yersinia enterocolitica. It's also based on the geographic location. So therefore, we will focus our discussion, our part 2 discussion, on these organisms. We'll review how to recover and identify these pathogens. So points to remember this part of the lecture. Make sure that you recognize the significant clinical findings, and what are those? The pathogenic mechanism based on the incubation period, travel history, and food intake, as well as initial laboratory findings, such as are there white blood cells and red blood cells in the stool. Remember the methods of recovery that now we're going to be talking about, and do review the characteristics of the mentioned intestinal pathogens on screening media, and we'll review some of the key identification features of each of these pathogens. So we'll see you in part 2.